Professor Fu, maybe you could react about Professor Unger, what I say, maybe about the medical autonomy, the limits of this autonomy, maybe about the physician errors and what you were suggesting about
Sure.
Professor Unger
actually,
presentation.
I might actually comment on two things, a little different from what you've just asked me. The first one is on the Kiwi share, because this melodious accent is actually from New Zealand and not originally Canada. My husband, in fact, used to run Pharmac, so I know of this. But my point is that it doesn't, this aggressive buying behavior, I think, cuts across public and private. This was happening in New Zealand, a government-run plan. It can happen in privately run plans. It is a phenomenon, I think, that cuts across public and private. So I don't see it as being related to the modality of financing. And just another point, I think that the private financing part is very complicated. And that we are no longer seeing a distinct split between public and private. Mm-hmm. It's more of a spectrum. And regulated private insurance is what you see in Colombia and Netherlands, regulated to try to achieve universality. And I think that's actually very different from the US-style system, at least pre-Obamacare, where there's a deliberate choice to leave many people uninsured. So I hear what you're saying, that it adds a level of corporatization, but it is within a distributed kind of system. So I think we have to be careful about drawing this kind of distinction between public and private. I don't think it actually exists anymore. There is a broad spectrum, and regulated managed competition a la the Netherlands covers everybody. But I see your point that costs are going up, but I guess the key question is whether they're getting any more from the perspective of the increased costs. Whether that's a good thing or a bad thing requires further interrogation, I think.
Maybe Alama, you have a comment on that. No, you don't want to comment about that. Professor Unger, no, but you can share it.
Yeah. No, with regard to the Kiwi regulation, obviously it's an issue for both public and private, and in Belgium it was intended to work in both sectors. I fully agree. I just say that from the perspective of the pharmaceutical industry, it might be a problem, and that in particular the private sector in the United States is capable of imposing Kiwi-like regulations. Second, with regard to Colombia, this is a system that I really thoroughly studied. I published repeatedly, maybe 10 papers on the health system in Colombia, and I can tell you it's catastrophic. We recently released papers, a series of papers on access of women with breast cancer in Colombia to health care. It's tremendous. The lack of access to second and third line hospitals, and the disease-specific mortality related to lack of access to care. And this goes together with very important costs. In fact, the insurances, the private insurances, try to prevent people to access complex care for the sake of controlling costs. And I don't think that this is what we want here in Europe. Really, we have nice social protections. It has worked very well for the patients, for the doctors, and for the pharmaceutical industry. And I think that so far, private insurances were confined to a marginal segment, but with the TTIP, things may change very rapidly.
So in one word, what is reshuffling the European system? In one word.
It means putting the doctor-patient relationship in the center of it, recognizing that if we want some autonomy for professionals, and I hope to have convinced you that this is important to have a sufficient, not a full freedom, but a sufficient autonomy for decent biopsychosocial care delivery, then health systems should better be prudent and provide a support for individual doctors, a technical coaching if you want, and a psychological coaching, organize teams, develops health systems, information systems that relate hospitals and GPs. There are several dimensions that would help reconceive health policies in all our countries in order to protect this beautiful relationship. We have inherited of a tradition of professionalism, and now it's in jeopardy, and I think we need to protect it.
Professor Flood, maybe it sounds very bureaucratic now.
Well, I would flip it around, and I don't think the doctor-patient relationship is the way to frame it, but the patient should be at the center. And the care that is provided can be provided by a multiplicity of providers and a multiplicity of settings. And that even this paradigm, as I've described it, may change substantially in 50 years or 100 years. So I think that we have to be very careful about how we frame this, and that, again, I'll refer back to my home jurisdiction of Canada, where physicians are probably the most autonomous in the world within a publicly funded healthcare system, and our healthcare system does not perform very well on quality, on safety, on access, on timeliness. Out of 12 countries in the Commonwealth Fund, we're only just beating the United States, which is a bit like shooting fish in the barrel from a health systems comparison perspective. So this isn't, I don't feel, a balm, a salve for it, because we still have that paradigm in Canada and it hasn't worked for us. I think we've got to be thinking about how our systems are constantly in renewal and in flux and in a constant state of self-reflection. I agree with that, but not just physicians, the whole system over time, so that new innovations can come in, older ones be replaced, but more importantly, more effective and efficient things replace less effective and less efficient in the delivery of care for our changing needs.